Welcome to the deep dive. Our mission today, let's map this pretty complex area covering general musculoskeletal introductions and removals.
Yeah, it's a really foundational range, isn't it? It covers, everything from very precise needle stuff to putting in and taking out major hardware. Sort of sets the scene for the whole musculoskeletal section.
Absolutely. And I think the key really isn't just memorizing numbers. It's about understanding the logic, the organization behind it all. We've basically boiled these codes down into three logical groups.
Right.
If you can get your head around the main differences within these three buckets, like why code changes, then you're well on your way to understanding the whole system.
Exactly. So let's start with Group I. This is what we're calling precision needlework. It covers injection and aspiration procedures, codes 2500 up to 2615. This whole group is really defined by where you're putting the needle and why you're doing it, the intent.
Okay, and right out of the gate, that therapeutic versus diagnostic thing seems critical. Like, take sinus tracts. Code 2500, that's therapeutic injection to standalone procedure. How's 2501 different then?
Well, 2501 is the diagnostic injection. And because you're often trying to, map out the tract, it frequently needs radiology guidance.
Ah,
So if that guidance is used, you'd report 2501 along with the SNI code 76080. So the Y completely changes the coding path.
makes sense. Moving to specific joints then. Some high-value injections target really distinct spots. We see 2526 for carpal tunnel, for instance. Are there any in this group where the coding depends on what happens right after the injection?
Yes, absolutely. And this is a great example of where you have to read the fine print. Think about the specialized enzyme injection for Dupuytren's contracture, that's 2527.
Right.
If the doctor does that injection and then right there in the same session manipulates the fascial cord, well, you've got to report that manipulation separately. Use code 26341 for that.
Mhm.
It just shows that the work might go beyond just the injection itself.
That's a really good point, a nuanced service. Okay, now let's tackle that tricky difference between tendon injections, 2550 versus 20551. It's all about where the needle ends up, isn't it?
It is, yeah. The key differentiator is really the specific anatomical site. So 2550 is for injecting into a single tendon sheath, ligament, or aponeurosis. Think like the plantar fascia, which is technically an aponeurosis.
Okay.
But 2551, that's specifically for injecting into a single tendon origin or insertion.
Yeah.
Right where the tendon meets the bone.
Gotcha. And are there any, exclusion rules here? What if something like PRP, platelet-rich plasma, is involved? Do these codes still apply?
No, they don't. And this causes a lot of confusion, actually. The CPT guidelines are clear. You shouldn't report 2550 or 2551 at the same time as the PRP codes. Those usually fall under the temporary Category 3 codes, like 0232T or maybe 0481T.
Wow.
That separation is definite because those specialized PRP codes already cover the injection work. It's bundled in.
Right, okay. So shifting from specific anatomy, let's look at procedures organized just by, volume, like the muscle count for trigger point injections, TPIs.
Yeah, for TPIs, that's 2552 and 2553. The difference is purely the number of muscles treated. So 2552 is for just one or two muscles.
Okay.
And 2553 is when you're treating three or more muscles. And importantly, the sources also cover dry needling codes 2560 and 2561. That's needle insertion without putting any substance in.
And that same muscle count logic applies there too, one or two muscles versus three or more. But the really critical instruction is you can't report the needle-only codes, 2560 or 2561, with the injection codes, 20552 or 2D553 for the same muscle, correct?
Exactly right. You're either doing an injection or you're doing needle insertion without injection. You can't bill for both on the same muscle group in the same session.
Okay, good clarification. Let's pivot now to arthrocentesis, aspirating or injecting a joint, or bursa. This seems grouped by a size hierarchy, which sounds fairly straightforward.
Yeah, it scales up nicely. 2600 is your small joint, think fingers or toes. 2605 is intermediate, like the elbow, wrist, or ankle. And then 2610 is for the major joints, shoulder, hip, knee.
So how does using imaging guidance, like ultrasound, change the code choice for these?
Well, if the physician uses ultrasound guidance, they have to pick one of the specific combo codes. 2604 for small joints, 2606 for intermediate, or 2611 for major joints.
Okay.
And this is really vital because these codes include the ultrasound guidance work already. So you definitely should not report this separate ultrasound guidance code, 76942.
Right, it bundled.
It's already bundled into that musculoskeletal code. Reporting it separately would be wrong.
Good to know. So we wrap up this first group, the needlework group, with a couple of others. There's 2612 for ganglion cyst aspiration and injection. Anywhere, location doesn't matter.
Correct, any location. But quick detail, use modifier 59 if you're treating multiple ganglion cysts.
Okay. And then 2615 is specifically for treating a bone cyst.
Right. And that brings us to the end of Group 1. Now we kind of shift gears completely into Group 2, fixation and hardware removal. This covers codes 2650 through 2697. We're moving away from small needle stuff now and into, inserting and removing significant hardware, implants.
Starting with simple removal, the coding seems focused on depth, like removing a foreign body from muscle at simple, 2520, versus deep or complicated, 2525. Is it similar for implant removal?
Exactly. The depth rule is key. Again, if it's a superficial implant removal, maybe a buried wire or pin just under the skin, you use 2670. And the sources specifically call this a separate procedure. But if you're going deeper, removing something like a screw, a metal plate, or an internal rod, then you report that using 2680.
Let's dig into a major rule here the sources highlight, this removal included idea. For a lot of these fixation systems, the code for putting it in already covers taking it out later.
Right. Absolutely. That's a fundamental concept here. When you report the application of, say, skeletal traction, that's 2650, or cranial tongs, 2660, or any of the halo applications, 2661 through 2663, the work involved in eventually removing that hardware is considered part of, included in, that initial application code.
So the basic assumption is the same doctor who applies it will remove it. But what if that doesn't happen? What if, someone else takes the hardware out later?
Yeah, well, that's the specific exception, and it's covered by code 211665. This code exists only for removing tongs or a halo when it's done by a different physician or practitioner than the one who put it on originally.
Okay, so it accounts just for that specific scenario where the usual inclusion rule gets broken.
Precisely.
Moving on to external fixation systems. The difference here seems to be about mechanical complexity, like the number of planes involved.
Yeah, the source material defines them based on how the pins or wires are set up. So uniplane external fixation, that's code 2690, uses pins or wires basically restricted to one plane. But when you step up to multi-plane systems, these are often complex frames, maybe like an Elizaroff device involving pins or wires in more than one plane, then you use code 20692.
And this is where maybe the cognitive work starts blending more with the actual procedure.
Yeah.
Tell us about the really advanced systems, the ones needing computer help.
Right, that takes us to 2696. This is for applying a multi-plane system that involves stereotactic computer-assisted adjustment.
Okay, stereotactic. What does that bundle in?
Well, the critical thing about 2696 is that it explicitly bundles all that extra technical work. It includes the imaging, the initial alignment, any subsequent alignments or assessments, and all the calculations needed to schedule those adjustments.
So it's quite comprehensive.
It is. And because it's so comprehensive, it means you should not report 2696 alongside the basic multiplane code 20692. It covers more ground.
Got it. And what if one of those complex systems needs, say, a part swapped out, like replacing a strut?
For that specific task, there's an add-on code. It's +2 along 697. That's used for the exchange, the removal and replacement of a strut on these complex fixation devices.
Okay, that makes sense. That brings us then to our final and probably most specialized category. Group 3, manually prepared drug delivery devices. Codes 2700 to 2705. First thing to really emphasize here is every single code in this little series is an add-on code.
That's the first flag. It immediately tells you they can't be reported by themselves. They must go along with a primary surgical procedure code.
Right.
And the definition of manual preparation is key. This means the physician during the surgery is actually mixing antibiotics or other drugs with some kind of carrier substance like cement and then shaping that mixture into a physical device, maybe like beads or a spacer.
Okay, making it right there.
Exactly, usually to treat or prevent infection. And crucially, these are reported only once per anatomical site, no matter how many beads or whatever are placed.
So the insertion codes then, plus 2700, plus 2702, plus 2704, they just depend on where the doctor puts this custom-made device. Deep space, inside the bone, or inside the joint.
Correct. Plus 2700 is deep space, like subfacial. Plus 2702 is intramedullary, so within the bone itself. And plus 2704 is intra-articular, within the joint.
And the main rule on the insertion side. Anything specific to watch out for?
Yes. The main thing is these codes are only for those manually prepared devices. You absolutely cannot use this series of codes if the surgeon is just inserting a prefabricated off-the-shelf drug device. Different coding applies there.
Okay, clear distinction. Now let's get to what feels like the critical compliance point, maybe the aha moment for this whole series, the removal guideline. There are add-on codes for removal too, plus 2701, plus 2703, plus 2705. They report taking these devices out right often when the infection's gone.
They do. They correspond to removing them from the deep intramedullary or intra-articular space, respectively. But here's the absolute crucial point, the one that really impacts compliance. If the removal of one of these manually prepared devices is the only procedure being performed during that operative session, if it's basically a standalone service, then you must switch back and report the general deep implant removal code 2680 instead of using the specific add-on removal code, plus 2701, plus 2703, or plus 2705.
Wait, hang on. So those specific add-on removal codes, they only apply if the removal is done alongside another primary procedure. If taking the beads out is the only thing happening, you ignore that specificity and just default back to the general 2680 code.
That's exactly it. It seems counterintuitive, but that's the rule.
Wow, okay. That reversal is a massive detail for getting the reporting right.
It is.
Yeah.
And that same switch back to 2680 also applies if you're doing an intra-articular removal plus 2705, and it leaves the joint basically without any remaining cartilage or stabilization structure. If there's no simultaneous primary service, you just fall back to the general deep hardware removal code 2680.
Okay, so let's try to synthesize this. What does this whole deep dive really mean for you, the listener, trying to master these codes?
Well, I think we've navigated the three main organizational groups that control this number range, right? First was the needle procedures, where accuracy really hangs on defining the site, the size, and maybe the muscle count. Second, we had hardware and fixation. There, you need to know the difference between one plane and multiple planes, and you absolutely have to remember that removal included rule and its exception.
Right.
And finally, we just covered those specialized drug delivery devices. The definition is all about that manual preparation, but the compliance really hinges on understanding that critical standalone removal exception that switch back to 2680.
Yeah, this deep dive really drives home that coding expertise is often about spotting those subtle, situation-specific details. Was it the tendon origin or the sheath? Was ultrasound guidance bundled in the code already? Was the removal done by itself? Those small questions make a big difference.
They do. And maybe if we connect this to the bigger picture, think about that stereotactic, computer-assisted external fixation code, 2696. We talked about how it explicitly bundles in all that cognitive work, the imaging analysis, the computation, the alignment planning.
Yeah.
It sort of raises an interesting question for you to think about as you process all this. In modern medicine, especially with advancing technology, where exactly is the line drawn between the physical hands-on procedure and the immense cognitive and technical preparation needed to actually execute it safely and effectively?
That's definitely something to mull over as you apply this newfound precision with musculoskeletal codes. We certainly hope this deep dive gave you the clarity you need to navigate this section with more confidence. We'll catch you next time.